Pterygium excision with conjunctival autograft. Young patient of 30 with this kind of pterygium. Unless we do conjunctival autograft in such cases, chances of recurrence are quite high. So the plan is to excise this pterygium and do conjunctival autograft. Only the conjunctiva which is thick and near the apex is being excised. The normal conjunctiva is not excised because in pterygium the conjunctiva is not the culprit. The culprit is this subconjunctival connective tissue. This Tennant's tissue is the culprit. It advances onto the cornea and takes the conjunctiva along with it, stresses the conjunctiva and encroaches onto the cornea. So we must trim this tissue very nicely. I'm pulling it and trimming it so that it goes far behind. At this time we must be very careful not to cause any injury to the tendon of the medial rectus. And now the Tennant's tissue on either side, superior and inferior, are being trimmed. The Tennant's on the superior aspect has been trimmed, and now the Tennant's on the inferior aspect is held in this way, and this is also trimmed. Must expose the sclera for conjunctival autograft. And now how to dissect the pterygium which is on the cornea. In this case I am taking help of this instrument. This is a crescent plate. Just sweeping it with the cutting edge, and I have to get a plane, a nice plane, so that I get a smooth surface, and I have got it. Once we get this, we can get a very smooth surface. Some pterygium like this in young patients, if we tend to tear it off, there can be many more tags. So this is a good way of dissecting the pterygium. And now I am removing the epithelium from the margin of this bare area. Yes, so we have got the sclera exposed. There is some bleeding, but I am not going to use any cautery in pterygium surgery, and neither I'm going to use mitomycin C. The combination of cautery and mitomycin C is dangerous. It can cause scleral necrosis. So this is the measurement. So I'm going to take a tissue of this, inject BSS just underneath the conjunctiva so that we get a plane between the conjunctiva and subconjunctival connective tissue. And we're going to remove only the conjunctiva and not the Tennant's. So this is a sharp Vanna scissor. I'm going to cut only the conjunctival tissue and getting a plane between the conjunctiva and Tennant's. dissecting this plane. This is the most important step, getting only the conjunctival tissue and leaving the Tennant's capsule behind. If we can do this, then the area heals very nicely and the Tennant's tissue gets covered by epithelium, the conjunctiva, easily. But if we remove the Tennant's, there is secondary healing, and if this eye requires trabeculectomy in future, becomes very difficult to do in this side. But if we take only the conjunctiva and leave the Tennant's behind, there will be primary healing, no scarring, and if any surgery is required in future, the Tennant's capsule will be easily separated from the sclera. So we have got the graft tissue, and this is a nice piece of conjunctiva. Only few fibers of Tennant's are attached to this tissue, and we can just take the graft now. And now we must take care not to place the graft upside down. We must take extreme care to do that. And this is some incisions on the bare sclera to get some fresh blood. And now the graft is placed, it is oriented nicely so that the limbal side is opposed to the limbal side of this area, and now the graft is sprayed and placed nicely. There's some bleeding, it will stop in a few minutes. After placing the graft in this way, press the area, press the tissue with two cotton tipped Johnson warts. This Johnson warts has been wet and squeezed, and when we cannot come out just like that, we have to roll it and see how nicely the graft is in place. This end is, there's some excess tissue, we can either trim it or we can tuck it just underneath the conjunctiva here. I'm tucking it like this. And now we are towards the end of the surgery. We just have to wait for few minutes, about 3 minutes, so that this tissue gets firmly adhered to the sclera. And now before at the time of removing the speculum, we have to look at this. There's a band like thing, it is clotted blood, but we cannot pull it. If we pull it, the graft may be dislodged. So I took a scissor and I cut that tissue. Now see these post-op pictures taken 40 hours after surgery. The eye was firmly patched for 2 nights and the patient has come today, and here it is. The graft is nicely in place without any suture. Cornea is appearing almost normal, and the patient is very happy. Thank you very much for your attention. Hope this video will help you in developing your surgical skills, particularly in managing your pterygia with conjunctival autograft, where you use fresh blood as glue.